All right, well, good morning, everyone. So we're continuing with the, I think this is the last in our introductory summer series. I'm delighted to be able to talk to you about atrial fibrillation give you a little bit of what I think is, the past, present, and future of treatment for atrial fibrillation. So go ahead and get started. So just again, particularly for our new fellows, to highlight why atrial fibrillation is an important issue. It's obviously highly prevalent. We consider the lifetime risk, and I'll show you what that means, for developing atrial fibrillation is 25% once you reach age 40. Currently affects over 5 million Americans and is projected to affect way more than that in the coming decades. Atrial fibrillation has tremendous effects on quality of life. It's associated with increased mortality and heightened risk of stroke. It turns out that about 15% of strokes in the United States are actually attributable to atrial fibrillation. So this is really a very, very prevalent and very morbid and problem. Here you can see the age distribution of atrial fibrillation in the population. Clearly, it's a disease that's much more common in elderly, peaking here in the 70s. But we do see a fair number of people here in the 40s, 50s, and 60s who have atrial fibrillation, and you'll see that that's going to be very, very important as we discuss treatment. So this is work from Don Lloyd-Jones from the Framingham study, looking at the remaining lifetime risk for atrial fibrillation. So a lot of times we, think about risk in terms of what's your risk for an event in the next year or in the next 5 years. But for atrial fibrillation, well, for many things, really what you're interested in is your lifetime risk. So this is a methodology that was applied to Framingham for a lot of different things, and here it's applied for atrial fibrillation. And what you see here, for example, so we have the curves for men and women, but for different ages. So if you start at age 40, okay, and you follow what your cumulative risk for developing atrial fibrillation, you'll see by the time you get into your 90s, your cumulative risk is about 25%. And if you start at age 50 and you haven't had atrial fibrillation yet, by the time you get to your 90s, you have about a 25% risk of atrial fibrillation. And you can see no matter what age you start at, 40, 50, 60, 70, or 80, and you've not had atrial fibrillation yet, you have about a 25% risk of developing it before you die. For women, it's a little bit less, maybe 23%. But essentially, it's about a 25% risk for everybody once you get to the age of 40 that you're going to develop atrial fibrillation. And here's data from the Mayo Clinic looking at survival from atrial fibrillation. So here's from atrial fibrillation diagnosis. This is the observed and this is the expected. In the population, you can see that there's this sharp drop-off here initially. So obviously many people come in acutely ill and have atrial fibrillation as well. So they recalibrated the curve to exclude this early period. So this is now looking if you survive more than 4 months after atrial fibrillation diagnosis, so a landmark analysis. And you can still see that if you have atrial fibrillation, your survival is overall worse compared to what it would be expected to be. Hazard ratio is 1.66. So it's a fairly significant increase in mortality associated with atrial fibrillation. As we mentioned, 15% of strokes are attributable to atrial fibrillation. Stroke severity tends to be worse with atrial fibrillation. And here, it's very important that the stroke risk is really independent of symptoms and is something that we really need to pay a lot of attention to. We're not going to have a lot of time today to discuss stroke risk, but this is obviously also a very important and evolving field. So the questions that I'd like to mostly focus on today are the following. What is atrial fibrillation? What is optimal therapy? What is atrial myopathy? And then do we treat the atrial fibrillation, the atrial myopathy, or both? So it's going to be a little bit of a different way of thinking about atrial fibrillation than many of you might have been thinking about it in the past. So here is an example of lead V1 ECGs from 4 different patients with atrial fibrillation. And the correct electrocardiographic diagnosis for every one of these tracings is atrial fibrillation. But my question to you is, are these the same disease, right? So look at this box over here. If you look, there are about 5 different little F waves in this box. Here, if you look in the same size box, there's, first of all, much larger amplitude, much more organized fibrillatory waves, and there are only 3 boxes. So it's a slower atrial fibrillation than what you see here. Similarly, over here, if you look here, you see much larger amplitude compared to what you see over here. Here you see only 2 fibrillatory waves in this box. Here you see 3. So there are a lot of things that we can see differences in atrial fibrillation on the ECG, but we really don't know how to characterize. Are these really the same disease? Are they different diseases? Should they be treated the same? Should they be treated differently? We really don't yet have the answers to these questions, but it's, I think, something that we're going to need to start to think about. And in fact, when we think about how we classify atrial fibrillation, there are a lot of different ways that we use, and I would say perhaps that none of them are particularly helpful in terms of helping us to decide how to treat a specific patient. So certainly people have used ECG descriptors, whether the AFib is coarse or fine. And again, what that means, we have no idea. This is an important differentiation, primary versus secondary atrial fibrillation. So primary being primary electrical disorder, secondary being clearly secondary to acute pneumonia or thyrotoxicosis or some other disease that once we treat it, it resolves and we don't have to worry about it in the long term. We also classify in terms of the type of atrial fibrillation, and this is going to be very, very important because this may have something to do with the severity or underlying myopathy that's associated with atrial fibrillation. Paroxysmal comes and goes on its own, persistent lasts really beyond 7 days and requires some intervention to restore sinus rhythm, and then the chronic variety. We also classify based on symptoms. We have silent AF and symptomatic AF. Again, does that make a difference? Well, it may make a difference in terms of our treatment choices. It may be more aggressive in somebody who has symptomatic atrial fibrillation. Clearly, we do focus on the type of underlying heart disease. We talk about lone atrial fibrillation versus any other kind of structural heart disease. And then there's the classification based on the autonomic type of AFib, the Kummel or vagal AF. That's probably not very common, but it still is a classification that we use. So again, none of these really have to do with a lot of underlying pathophysiology of atrial fibrillation, but these are the best classifiers that we have right now. So I think it's also important that we understand what the underlying mechanisms are for atrial fibrillation. So the original hypothesis for the mechanism for atrial fibrillation was the multiple wavelet hypothesis by Gordon Moe many, many years ago. There have been a lot of other proposed examples, macro reentry, micro reentry, focal firing, and I'll show you examples of some of these. And the current mechanism in vogue is rotors. I'll show you what that is. And this is a schematic that was put together by Hugh Calkins. This is now looking at the posterior left atrium. You can see the pulmonary veins, and he's trying to depict many of these mechanisms here. So these are the autonomic ganglia that are on the epicardial surface outside the pulmonary veins. Here you see these stars are the rapid firing foci that come from the pulmonary veins. These are micro-reentrant or rotors in these areas. These are larger areas of reentry or rotors. And I think the point of this schematic is nobody's really sure which of these mechanisms are operative. Are they operative in all patients at the same time? Do different patients have different mechanisms operative at different times? And obviously this is going to be very important in terms of understanding how to treat our patients with atrial fibrillation. So one of the key areas of interest in patients with atrial fibrillation is the pulmonary veins. And the reason that the pulmonary veins are of such great interest is if one looks pathologically at the junction between the left atrium and the pulmonary vein, you can see that the left atrial muscular tissue extends into the pulmonary veins. And we can actually record atrial potentials well into the pulmonary veins when we stick a catheter in here. And this tissue is very arrhythmogenic. And this was first identified by Michel Hasseguer in his classic New England Journal paper in 1998. What you see here, the top tracings are ECG, so you can see sinus rhythm here, and then here's the onset of atrial fibrillation on the ECG. Here you have a catheter that's sitting inside the right inferior pulmonary vein, and you can see that you have two different deflections here. So this first deflection is an atrial electrogram from the left atrium. And then this large potential here is actually what we call a pulmonary vein electrogram. So it's really also an atrial recording, but it comes from the atrial tissue that's sitting in the pulmonary vein. And at the onset of the atrial fibrillation, what you see is this rapid firing of this pulmonary vein tissue at a cycle length of 170 milliseconds. And then you see this degradation of the electrogram into clear atrial fibrillation. So this is a focal atrial tachycardia or pulmonary vein tachycardia starting in the pulmonary vein and then degenerating into atrial fibrillation, almost suggesting that there maybe are two different mechanisms operative in this patient with atrial fibrillation, both a focal firing and then some sort of substrate-mediated reentry that sustains the atrial fibrillation, at least for this period of time. So I wanted to give you a visual here on what rotors might look like and how this might be related to atrial fibrillation. So this is a simulation done by one of my colleagues. It uses the Fenton-Karma model for propagation. And this is basically a sheet of myocytes. And what you'll see here is that there'll be initial propagation down here, and then there'll be an interruption that will start these spiral waves. And you'll see that there's going to be what I'm telling you in advance what you're going to see, so it won't be too surprising. You'll see that there's going to be a consistent rotor here, what we call the mother rotor, and then you'll see it'll break out into daughter rotors. And you could, I think you'll get a visual understanding for, if we can play it, a visual understanding for what rotors are and how that might be involved in atrial fibrillation. So there we go. So now you can see this is the spiral wave, and this thing is basically, it's self-perpetuating, but it generates these other daughter waves. And you can imagine how this chaotic activation then results in atrial fibrillation. And as long as you have this self-perpetuating mother rotor, the atrial fibrillation will continue. And that's one of the current theories for the mechanism underlying atrial fibrillation. It makes very pretty pictures when you simulate. So one of the biggest questions that we've had regarding atrial fibrillation is, of course, the rate versus rhythm control issue. And I think the main question that we have is atrial fibrillation is associated with an increased risk in stroke. It's associated with an increased risk of mortality. How can it be that prevention of atrial fibrillation is not associated with benefit? And this has been debated and discussed and studied for multiple decades. I'm not going to go into a large analysis of this. We have discussed in this grand rounds, I think several times already, the Cabana trial, which is the most recent large-scale randomized trial that's studied the effect of catheter ablation versus medical therapy in atrial fibrillation. For those of you who have not yet read it, it's really an important trial, and I suggest that you read it. The Cliff Note summary is that you can interpret the trial any way that you want, and meaning that there's a intention to treat analysis that shows one thing, and then there's an on-treatment analysis that shows a completely different result. So please look at it, and if you haven't, and I'm going to give you my general interpretation and some further data that's come out since then to, I think, really provides continued supportive evidence that catheter ablation is an important and good treatment for atrial fibrillation. And I think in particular, we can identify certain groups who really benefit from atrial fibrillation ablation. Obviously, patients who are symptomatic, and when I see an asymptomatic patient in the office, it's always a bit of a struggle for me because you can't really offer to make the patient feel better if they're asymptomatic. But if they're symptomatic, you can actually offer them to feel better with ablation. The other groups that have, I think, shown really strong benefit from catheter ablation for atrial fibrillation are the younger patients and patients with heart failure. So basically, if you're asymptomatic, old, and don't have heart failure, and you have atrial fibrillation, then it becomes more of a question about how you should manage it. But otherwise, everybody else seems to benefit from catheter ablation. So this is a study published in JAHA in last year, comes from the Korean National Health Insurance Database. There's a lot of interesting things from the study, but you can see down here, they ended up comparing, and again, it's not a randomized study, it's just an observational study, and they did all of the propensity score analyses to compensate for differences in patient characteristics. They ended up with about 9,000 ablation patients and 18,000 medical therapy patients. But interestingly enough, look at this, 3/4 of their patients did not receive any treatment. That's sort of astounding. But anyways, what they focus on in this paper is the comparison of the outcomes in patients with ablation versus medical therapy. And you can see here over a period of about 4 years, whether one looks at their composite endpoint of death, heart failure, or embolic events, or one looks at just all-cause death, the group treated with ablation does substantially better. It's about a 60% reduction in the event rates for either the composite endpoint or for mortality. So it's really a substantial reduction in mortality for patients treated with catheter ablation in this study. Here's another meta-analysis that was published also in 2020. Total N, 241,000, and it does include Cabana, which only had about 2,000 of these patients. Just important thing to note here, again, relatively young age. You're talking about 64 years old in these studies. So again, supporting the notion, as you'll see, that younger patients tend to do better. But they do have a variety of comorbidities, hypertension, diabetes, coronary disease, 15% heart failure, CHA2DS2-VASc scores of over 2 or more in 60 to 70% of these patients. So they're really a fair number of patients that have comorbid diseases. And here's the meta-analysis table for mortality. Here looking at the various studies, adding in Cabana, and what you see here, the final hazard ratio is 0.62, so suggesting that there's a 38% reduction in mortality with catheter ablation for treatment of atrial fibrillation. If one looks at heart failure hospitalizations, one also sees a 36% reduction in heart failure hospitalizations for patients treated with catheter ablation. So again, I think particularly for the subgroups that I mentioned, I think the data is becoming stronger and stronger that catheter ablation is a better treatment than medical therapy for atrial fibrillation. Now, it would be nice to say that catheter ablation is a great treatment for atrial fibrillation, but unfortunately I can't tell you that. And I think this is a paper from the New England Journal, also in 2015, the STAR-AF2 trial. And I think this is still pretty much reflective of the state of catheter ablation for atrial fibrillation today. Basically, this was a randomized clinical trial to look at 3 different strategies for ablation of atrial fibrillation. One strategy being just pulmonary vein isolation. Second strategy being pulmonary vein isolation with additional linear ablation, so across the roof, and what we call a mitral isthmus line from the pulmonary vein to the mitral valve. And then a third strategy, which is pulmonary vein isolation with ablation of complex fractionated electrograms. So a targeted approach based on the electrograms. And the authors hypothesized that these more aggressive approaches would actually be better than just pulmonary vein isolation. It turns out that the more aggressive approaches were not better than pulmonary vein isolation. And I think the disappointing thing here is you could see that the success rates in a year are in the 50 to 60% range. And I think that's still true today for catheter ablation for persistent atrial fibrillation. We have a success rate of about 50 to 60%. For paroxysmal atrial fibrillation, I think the success rates are now 70 to 80%, so they're somewhat better. But our approach with just ablation for treatment of atrial fibrillation is still inadequate. Nevertheless, catheter ablation does seem to be better than medical therapy. And you can only imagine that if we were somehow able to improve our outcomes with catheter ablation, we might actually show even better long-term outcomes in terms of mortality, stroke reduction, prevention of heart failure. So, because I think there are really 2 approaches to trying to improve outcomes with atrial fibrillation ablation. One approach would be to say, well, if our current ablation approach doesn't work, let's try to adjust our ablation and see if we can do ablation better. And there's been a lot of focus on that. And I think, if you look at the STAR-AF2 trial, the notion of doing more ablation does not necessarily get you added results. So there's going to be some limitations to the approach of trying to just optimize the ablation to improve outcomes. The other approach is to sort of consider, well, what's causing the atrial fibrillation itself? And maybe we should target the underlying substrate for atrial fibrillation or the underlying myopathy that leads to atrial fibrillation. And I use Dr. Cohen as my key example for why this is really very important. If Dr. Cohen takes one of my patients and who's got a 90% mid-LAD stenosis and opens it up and puts in a stent, if I walked up to him and said, listen, you opened up the artery, don't worry about what the cholesterol is. We don't want to put the patient on the statin. The artery's open, we're done. He would look at me like I was, from another planet. Yet, that's really what we currently do with atrial fibrillation, right? We say, all right, we'll do an ablation and we're not going to worry about what the underlying substrate is and the disease processes that led to the atrial fibrillation. We're going to leave those alone. And I think that's part of the problem with our approach to atrial fibrillation. And you'll see that there are real opportunities to now focus on the atrial myopathy that leads to atrial fibrillation and see if that can actually help us improve the outcomes. Now, atrial myopathy is not really well defined. Obviously, one can look at dilatation, dysfunction, and fibrosis, and those are really key elements of the myopathy. So, and again, this is what I was trying to indicate before. You know, once a patient has atrial fibrillation, this is very late in the disease process. It's like coronary disease. When somebody manifests with an acute myocardial infarction as their initial presentation for coronary disease, that's not the first time that they've actually had coronary disease. It's really been a long timeline. And the same thing is true with atrial fibrillation. There's going to be early fibrosis, mechanical atrial dysfunction, atrial dilatation that's going to progress over time. Some of it may be detectable even before there's atrial fibrillation, and maybe this could be a phase for intervention before patients have atrial fibrillation. We're not there yet because we haven't defined yet enough which substrates are targetable, but I think this is the way we have to start to think about atrial fibrillation if we want to have some better outcomes once the patient has atrial fibrillation. So we have a lot of tools at our disposal to look at atrial myopathy. So there's certainly the ECG. So this is looking at V1, what we call the P-wave terminal force. You can see here, or left atrial enlargement. It's clearly very prominent. So ECG is certainly one type of analysis to look for atrial myopathy. This is data from Nasir Marouche when he was at Utah, looking at cardiac MRI and delineation of fibrosis. And he defines different stages of fibrosis. You can see colored in the green. And although this is not yet a clinically available tool to evaluate atrial myopathy, it clearly could be very, very helpful. This is just looking at voltage mapping for patients with atrial fibrillation. So again, we're looking at the back of the left atrium here. Normal voltage would be in purple, and you can see that there's only very small areas where you have normal voltage, a lot of areas of low voltage. And that's, again, probably due to fibrosis. And in fact, there are a lot of different tools that exist to define atrial myopathy. You could use echo for strain analysis, the surface ECG, which we looked at the very beginning, biomarkers, the MRI, looking, and some of the work we've done looking at 4D flow. And one thing I'll show you is looking at epicardial fat on CT. And these are all ways that we can at least evaluate the myopathy underlying atrial fibrillation. And we sort of need to figure out which of these factors are the most important in terms of generating atrial fibrillation and which ones are actually modifiable and can be used to actually improve and treat atrial fibrillation. All right, so now we are going to try to address the question of, do we treat the atrial fibrillation? And this is, again, talking about targeted treatment of atrial fibrillation or the atrial myopathy, or both. And I think the obvious question is the obvious answer is that we want to treat both. So if I were to ask you, I don't have an audience response system today, but if I was to ask you which of the following are established treatments for atrial myopathy, so amiodarone, digoxin, diltiazem, catheter ablation, or weight loss, some of you may say none of them, but it turns out that weight loss is probably the only one on this list that actually is associated with treatment of the atrial myopathy. And my job in the next few minutes is to try to convince you of that. So the key leaders in the field are our colleagues in Australia who have done a variety of different studies. This is published in 2013. It was a randomized study in patients with symptomatic atrial fibrillation and BMI over 27. And they had two groups. The intervention group was a physician-led weight loss program, and the control group was a self-directed general lifestyle measures. So in other words, what we often do with our patients, we say, listen, you're overweight, you need to work on losing some weight. And then we send them out and we hope that they comply, but most of the time they do not. So again, so you can see it's a fairly young population, age 60, BMI is around 30, so still pretty obese population. And the results are actually very impressive. So you can see here on the top, waist circumference and BMI. The controls are the open circles, the closed circles are the intervention group. So you can see dramatic improvement when you have a physician-led weight loss program in terms of BMI and waist circumference. And here what you have in the bottom panels here are the symptom burden score and symptom severity score for the atrial fibrillation. And this is going out to 15 months. And you can see that the intervention group actually does a lot better in terms of both symptom severity and symptom burden compared to the control group. So this was, I think, very, very telling. The group that went on to do another study, the ARREST-AF cohort study, and this is also very interesting. This was not a randomized study, but they took their patients who were going to have atrial fibrillation ablation. If they had a BMI of 27 or more and more than one cardiac risk factor, they were able to participate in this study. And in this study, they did, like I said, they didn't randomize them, but they just offered the patient aggressive risk factor management. Only 69 of the 165 agreed to do aggressive risk factor modification. So most of them refused. And then there are a bunch that lost to follow-up. So you can see we end up with a fairly small group of patients, but 61 with aggressive risk factor modification by choice and 88 in the control group. And these are the results for freedom from atrial fibrillation out to 2 years. And this is after a single atrial fibrillation ablation procedure. And you can see that the patients who opted for aggressive risk factor modification had almost a doubling of their freedom from atrial fibrillation compared to those that did not agree to have risk factor modification. And this is just looking after multiple procedures, and the results are essentially the same. Dramatic improvement with the aggressive risk factor modification compared to the control group. So again, they've done a variety of studies. This is now their legacy study looking at about 400 or so patients, and they divided them into 3 groups. Those that had more than 10% weight loss, those that had 3 to 9% weight loss, and those that had less than 3% weight loss. And again, we're talking about, you know, a fairly young group of patients with atrial fibrillation, those in their 60s, but, you know, still with a lot of comorbid diseases, as you would expect in patients who have obesity. You can see the BMIs here, again, are around 33. And what we see here, this is now looking at all treatments. So, you know, all treatments the patient got and looking at total atrial fibrillation-free survival. And you see almost what I would say is a dose response. Those have the most weight loss have the best outcomes. Those with the middle weight loss have intermediate outcomes, and those with no weight loss have the worst outcomes. And again, this is out to 5 or 6 years. So it's very, very robust data showing the impact of weight on the outcomes after catheter ablation. So one final study from the group, which is the reverse AF study, and I think this is, I think it at least should raise in our consciousness whether this weight loss is actually serving to reverse the underlying atrial myopathy that exists in atrial fibrillation. So again, they're talking about these, about 400 patients here, BMI 33, total follow-up of 4 years. And again, we're looking at patients with essentially no weight loss, intermediate weight loss 3 to 9%, and those with over 10% weight loss. And at baseline, you can see the distribution here of paroxysmal and persistent atrial fibrillation. We're going to look at the follow-up data, and we're going to look at it based on the type of atrial fibrillation. So you're going to look at the patients who progress over time from paroxysmal to persistent atrial fibrillation. So that's in the purple. So if you have no weight loss, about half of the patients progress. If you have intermediate weight loss, about a third of the patients progress. And if you have a lot of weight loss, almost nobody progresses from paroxysmal to persistent. Here in the yellow, we're going to look at people who have what we call reverse progression, right? Who start out with persistent and then end up with paroxysmal atrial fibrillation. If you don't have any weight loss, essentially nobody has reversion of their atrial fibrillation. If you have intermediate, it's about 17%. And if you have a lot of weight loss, 36%. So really dramatic differences in what happens to your atrial fibrillation over time. And then even if one looks at AFib-free, only about a quarter of the patients without weight loss end up AFib-free, about a third with intermediate weight loss, and then half of those with over 10% weight loss end up AFib-free. So you can see here, it gives you sort of a visual for how the weight loss may actually be a very, very important intervention. That, again, these are also accompanied by other drug and ablation interventions, but this is an adjunct that actually helps to improve your outcomes with atrial fibrillation ablation. And this is actually one sort of astounding thing. So just going to look at this line. So we're now going to look at total freedom from atrial fibrillation in patients who did not have any AFib ablation. So in patients in group 1 who had minimal weight loss, you can see it's only about 13%. But those who had a lot of weight loss, 45% ended up with no AFib and no AFib ablation. So again, really, really impressive results. And I think it's based on these data that the updated guidelines in 2019 introduced this as a class 1 recommendation for treatment of atrial fibrillation. And in fact, this was the only new class 1 indication added to the guidelines, which is weight loss. So I think it's important for us to consider how does weight loss and risk factor modification work. Certainly, it could be the weight loss itself, could be effects on other comorbidities like sleep apnea, diabetes, or a combination of all of these things. Another important question is all these studies were done in Australia. Can it and will it work here in the United States? We really don't know the effect, what the mechanism is. Is it a reduction in visceral adipose tissue, perhaps a reduction in epicardial or left atrial adipose tissue? And that's an area that we are very interested in that I'm going to tell you about shortly. So, turns out one of the world's leading experts in epicardial fat is here at the University of Miami, our colleague Gianluca Accavellis. He's done really a lot of foundational work and has been working with us in trying to understand how this might be an issue in patients with atrial fibrillation. And I think the important thing to understand about the epicardial adipose tissue is that the adipose tissue sits directly on the atrial myocardium. There's no fascia that separates the adipose tissue from the myocardium, and therefore there's free interchange of all sorts of adipose cytokines from the fatty tissue into the atrial myocardium. And those could be pro-fibrotic, pro-inflammatory cytokines, some cytokines that might affect ion channel function. And this could be what's serving as the promoter of the substrate for atrial fibrillation. On a clinical basis, if one looks at the Framingham heart study, they showed that in their case, pericardial fat, and there's a huge difference between pericardial and epicardial fat, but a lot of that has to do with the technique for measurement. But it was shown to be an independent multivariable predictor for development of atrial fibrillation with a hazard ratio of 1.3. And if we look, there are a lot of studies that have evaluated the importance of epicardial fat. This is now in terms of predicting outcomes following catheter ablation for atrial fibrillation. And if one looks at all of these studies showed significant adverse effects of increased epicardial adipose tissue on outcomes after catheter ablation for atrial fibrillation. So suggesting that this could be an important target. So in a study that Gianluca did, he actually looked at the effect of liraglutide, which is a GLP-1 agonist, on epicardial fat. In this study, compared it to the liraglutide to metformin. Now, this is not in patients with atrial fibrillation. This is just in patients with obesity treated with patients with obesity and diabetes treated with these two drugs, with liraglutide and metformin. And you could see that with liraglutide, there's dramatic reductions in epicardial fat that you see even as early as 3 months. So based on the data that's out there about obesity and the strong link, if not a mechanistic link, certainly an epidemiologic link between epicardial fat and atrial fibrillation, we came up with a clinical trial to try to actually look at the effect of liraglutide via its effects on either weight loss or epicardial fat on atrial fibrillation. This is a clinical trial that's sponsored by the NIH, and we are still currently enrolling. And I'd like to share with you some of our, at least one preliminary result from the trial. Just to give you a quick idea, it's patients with either persistent or paroxysmal atrial fibrillation, BMIs over 27, and it's patients who are have already decided that they want to have a catheter ablation procedure for treatment of atrial fibrillation. The protocol is actually fairly simple. At enrollment, the patients get randomized into one of two treatment groups. The one treatment group would be standard risk factor modification. So we use a risk factor modification program I'll show you shortly. That's basically a copy of what they do in Australia. The other group gets risk factor modification plus liraglutide. So this is a daily injection that they have to get. And one of the unique aspects of this trial is we decided that it might be a good idea to treat the patients if you do get some substrate reversal or remodeling with either risk factor modification or with the addition of the liraglutide. It actually might pay to do this for a period of time before doing the ablation. So we have a 3-month period of substrate stabilization, we call it, prior to ablation. Patients continue on whatever treatment they're getting, and the liraglutide continues for 6 months post-ablation. We're looking at CT and echo for measurements of atrial function and also for the epicardial adipose tissue, and also then blood biomarkers to look at pro-fibrotic and pro-inflammatory markers. So it's a fairly straightforward design. This is just, again, looking at what's involved in the risk factor modification program: weight management and exercise, control of lipids, sleep apnea, hypertension, diabetes, smoking cessation, and alcohol. So all things that are generally good for the patients. But we have a program that's run by Teresa St. Philippe, and she does an outstanding job making sure that we get these all optimized. And by the way, that's become our standard for any patient with atrial fibrillation who's going to have an ablation. We try to optimize all of these factors to improve our outcomes. So how are we doing so far? So this is looking now at the change in weight from baseline. So there's a percent change. In the red, you see just the risk factor modification group. And in the blue here, you see the risk factor modification and liraglutide. So this is at enrollment, which is generally about 3 months prior to the ablation procedure. So this is by the time they get to the ablation procedure. And you can see that we do get some weight loss, maybe 1.5% in patients with risk factor modification, but we get about 5% in patients with risk factor modification and liraglutide. So they're coming into their ablation procedure already with a good amount of weight loss. Remember, 5%, and in the Australian studies, if you're over 10% weight loss, that's where you really got the best bang for your buck in terms of the outcomes for catheter ablation. So hopefully this continues down, and if we get into that 10% range, following the ablation procedure as well. And working with Noam Alperin and Joel Fishman, we have now a very elaborate system to use CT to measure epicardial fat. And you can see we actually are able to subcompartmentalize the epicardial fat. In the purple is the left atrial epicardial adipose tissue, and then the rest is just the other atrial adipose tissue, the other cardiac adipose tissue. So we're compartmentalizing that, and we'll have those results available hopefully soon as well. But the story doesn't stop there, because we do believe that the epicardial adipose tissue is serving as some sort of depot that's leading to the substrate changes in the atrium that are promoting atrial fibrillation. And we think that if we can figure out what exactly those humors are that are being released from the epicardial adipose tissue, we actually might find some new targets for treatment of atrial fibrillation. So we have another study that just got funded this year, looking at a transomic analysis of epicardial adipose tissue and atrial fibrillation. So there are 3 aims. One is a proteomic aim, and basically this is looking to evaluate the associations of left atrial epicardial adipose tissue to biomarkers associated with atrial fibrillation, stratified by race and ethnicity. So it's very interesting. If one looks at the Black population, they have lower risk of atrial fibrillation than whites. And it also turns out that Blacks have less epicardial adipose tissue than whites. And the question is, if one looks at patients, at Black patients with atrial fibrillation, are we going to find that relationship of epicardial adipose tissue disappears or gets eliminated once they have atrial fibrillation? So again, suggesting that would be implicated in the development of atrial fibrillation. So we're basically looking for any patient who has had recent onset atrial fibrillation within 6 months, and the study really involves just a CAT scan and a blood test. So it's very, very simple. We have a genomic aim. So this is a study where we are looking at patients who are undergoing cardiac surgery with Dr. Lamelas, who's helping us out here. And we're looking at patients with and without atrial fibrillation. We actually take a biopsy of the left atrial adipose tissue, and we're going to be looking at the transcriptome in the epicardial adipose tissue compared to, for example, the subcutaneous adipose tissue to see if there are profibrotic or pro-inflammatory proteins that are accentuated in patients with atrial fibrillation. And finally, we have a metabolomic aim where we're going to be looking at cross-sectional associations between the epicardial adipose tissue and untargeted metabolomics. This will be done in the MESA study, in the Dallas Heart study, and the Rotterdam study. And we're hoping that between the three of these, we will identify some new and unique targets that could serve as adjunctive targets for treatment in patients with atrial fibrillation. So we spent a lot of time talking about these issues. Unfortunately, I don't have good answers for any of them yet, but I think these are things that we need to start to focus on if we want to really continue to improve our outcomes for atrial fibrillation. I think we do need to be able to better subclassify atrial fibrillation, because not every patient with atrial fibrillation is the same. It's a different disease in different patients, and we see that all the time. We see patients who respond extremely well to catheter ablation. We see patients who, no matter how many times you do catheter ablation on them, they have recurrent atrial fibrillation. We need to be able to figure that out and be able to assess how we develop optimal therapy. And we need to figure out how to best diagnose this atrial myopathy, and then what are the right targets that we have to treat the atrial myopathy as an adjunctive therapy to our ablation to ultimately improve outcomes. So I think it's an exciting area, particularly for our new fellows. This is a lifetime, a career for a lifetime for those that are interested. It's certainly been an interesting ride for me, and I'm happy to take any questions.
Hi, Dr. Goldberger.
Yes.
Great lecture. You mentioned all the benefits of weight loss on AF and a physician-managed program, which of course is what cardiac rehab is. So unfortunately, a qualifying diagnosis right now doesn't include AFib, but it would be wonderful in the future to have some kind of research study here to help bolster the argument that maybe AF should be added to the list of qualifying diagnoses for physician-managed cardiac rehab.
Yes.
Yeah.
No, I agree 100%. I think we are actually trying to figure out what are the barriers to doing this. And I can tell you, I mean, patients don't want to pay for some of these things independently. So if it's not going to be covered, they're not going to do it. If it will be covered, they will do it.
Right.
So it's really a challenging issue. But if the outcomes are really that much better, then it really should be a covered service.
Yeah.
Thank you.
Jeff, I have a question. So in the papers, in the data that you showed, the meta-analysis, there's a significant difference between the randomized clinical trial and the observational trials. I mean, we always see that. And I think it's not a good practice to mix randomized trials and observational trials in meta-analysis, because you end up with a response that the author of the meta-analysis wants instead of the actual truth. So I think that those slides, I'm playing devil's advocate here. So I think that those slides are a little bit biased. And I think that it's biased that a treatment for atrial fibrillation only is 50% effective.
Well, yeah. So the last one, I don't know that that's a bias. That's the reality. I mean, I think.
Yeah. Okay.
That's unfortunately what it is. I can tell you preliminarily in the LEAF trial with the adjunctive therapy, we're seeing better outcomes than 50%. So I think there are ways that we can improve that. That's number one. And your point about the meta-analysis is obviously very important and very true. I mean, there are a couple of things I would say. Number one is the observational studies had over 200,000 patients. The Cabana had only 2,000 patients. So I mean, I think that's why you see that in terms of the contributing to the overall results, it only contributes a very small amount. And the other thing is that in that meta-analysis, they appropriately included the intention to treat data for Cabana, but in the observational studies, it's not intention to treat, it's on treatment. So if you look at the on treatment analysis for Cabana and the on treatment for the observational studies, they're going to be much more in line than what was presented over there. So again, a lot of it is the way that you look at these data, and the data are not perfect. I think that's clearly correct. But we have to make decisions today for our patients based on the best data that we have.
The other thing is there such a thing as a statement on the acute management of AFib? Because that's one of the most frequent. I mean, it's so relevant. It's one of the most frequent consultations in the hospital, and one of the it's a very frequent visit to the ER. So when I was in charge of the acute care committee, somebody proposed a scientific statement on the acute management of AFib just to standardize things, because one says one drug, that says amio, that says diltiazem, beta blockers, shocking, no shocking. And is there such a thing as a statement or a uniform treatment or a guideline on how to manage that?
I believe that there is a section in the AF guidelines on acute management. I would have to go back and look.
But those are old, right? Those are old.
Yeah, so the original guidelines were 2014, and then there's the focused update in 2019. Yeah.
One question, Jeff.
Yes.
Is there any known role for the atrial myocardial tissue in the pulmonary artery? And does, after doing an ablation, help elucidate what that might be, or is it totally non-functional?
The role of the atrial tissue in the pulmonary vein
artery. The electrical, the atrial myocardial tissue and its electrical signals in the pulmonary artery. Do those serve some normal physiologic function, or is that unknown? And is looking at that after ablation helpful to see whether it does something? Yeah, so
it's a great question. I don't think anybody really knows. It's really a small sleeve of tissue that extends from the left atrium into the pulmonary veins. There are a lot of studies that have looked at atrial function pre and post ablation. There are certainly concerns when you do extensive ablation, and this is not pulmonary vein isolation, but when you do pulmonary vein isolation, and there are a lot of targeted ablation for a lot of different areas, that you can eliminate enough atrial myocardium to create sort of a stiff left atrium, and it becomes non-functional or poorly functional. So that is a concern. Not so much, I don't think anybody's seen that yet with just pulmonary vein isolation.
Hey, Jeff, I have a question that sort of relates. And I was intrigued by your, the images that you showed of that particular area, as well as the clinical findings of weight loss. And the question really revolves around, you mentioned, the adipose tissue that might be there and influencing that area. But what about morphologic changes that occur in that area secondary to things like volume status of the patient, hypertension, things that you would assume would get better with significant weight loss? And might that be a contributory factor to the development in that particular area depolarizations that lead to atrial fibrillation?
Yeah, so I think it is likely to be multifactorial. I mean, again, it's very hard. A lot of these things trend in the same directions, right? So it's not always easy to attribute, one particular change to, and be a purist about, that all of the effect is related to that. There are some studies that have looked at blood pressure control and outcomes after atrial fibrillation, and they've not found that strict blood pressure control improves the outcomes after atrial fibrillation ablation. So again, it doesn't mean that controlling your blood pressure is not going to be helpful, but at least in the randomized clinical trial, they did not find that it was beneficial. All right, I think our time is up. Thank you, everyone. Thank you for the great questions. And hopefully when we talk about atrial fibrillation next, we'll have some even better answers. Have a good day, everyone.